Hi everyone, Dr. Hall here, and we're going to do Unit 9, talking about healthcare professionals. So before we talk about professionals who work in healthcare, let's just be clear about what we mean when we're talking about professionals versus other types of workers. And it seems like a silly distinction, and in some ways it is, but it also has some meaning. So you can have an occupation or you can have a profession. An occupation is a job, and it's a job that requires expertise and training and skill. Whether you are a welder or whether you are a restaurant server or whether you work in IT, all of those things require expertise, training, and skill. Professions require all of those things, but in general, they also mean that you've had some extra graduate education. So usually you've gone on to do not only 4 years at college to earn a bachelor's degree, but often some additional training after that. You've gone to law school or dental school or gotten a master's degree in engineering. So you've had really a high level of education. So that's what we're talking about when we're talking about professionals. There are some characteristics that apply to all of the professions in general then, which is kind of a further way that they kind of distinguish themselves from kind of a general type of employed worker. One is that there's this really lengthy and really rigorous education and training, right? So it's really hard to get into law school, for example, and you have to work really, really hard and pass these exams and become licensed. You have to pass the bar, right? So it's very difficult to actually become a professional. There's a lot of work that you have to do. And so that's also going to require a lot of expertise and judgment. So when you are a professional, you then become an expert in that field. There's also an expectation that there's a dedication to the public good and an ethic of service. So, for example, for healthcare workers, particularly, it doesn't matter if it's the end of your shift, if you're an ER physician, if you're in the middle of taking care of a patient, you finish taking care of the patient. So, you will kind of go above and beyond for the sake of your client or your patient or whoever it may be. It's not just a job, it's something that has meaning and for which you have a certain sense of dedication. And also that you will respect that public welfare over personal gain. You're not just in it for the money. Hopefully, you're not just in it for the power. You're in it because you want to make a difference in the world and you're really committed to that. Professional occupations require certification and credentialing or licensure, so there are usually pretty rigorous standards that have to be met in order to earn that license or credential. And then you belong to professional organizations. So whether it be the American Academy of Family Physicians or whether it be the Society of, I don't know, electrical engineers, I don't know. And then these professional organizations have membership requirements that usually mean that you have to attend certain numbers of hours of continuing education in your field. It might mean that you have to perform certain numbers of service activities in your field, but there are additional kind of requirements on you above and beyond what you're doing when you kind of go to your day-to-day work so that you can maintain that expertise. And then society in response gives some benefits to professionals. So in general, they have relative autonomy. They tend to have, in general, a lot of control over what they do and how they do it. They are granted a lot of discretion, and they don't have a lot of people necessarily telling them what to do every moment of the day. They also, in terms of autonomy or that ability to self-regulate, that also usually applies to the profession. So the profession can set standards for itself. So the Society of, so for example, the American Association of Family Physicians has its own accrediting board that decides who can be certified as a family physician and maintain that credentialing. So they kind of police themselves in terms of making sure that everyone is as expert as they need to be. And then society grants them typically high levels of prestige and respect. So if someone is a lawyer or someone is a judge or an engineer or a physician or a nurse practitioner, right, we acknowledge that this is someone who has a very high level of training, expertise, and has a lot to add. And in general, they also tend to be compensated quite well. So that's kind of how it goes, right? All right, so this kind of combination of requirements and benefits is what's often referred to as a social contract, right? So the training to become a lawyer or a dentist or a physician is really grueling. It's really difficult. Often then when you're in practice, the hours that you work can be really long and grueling and difficult. I got to tell you, I was in a hearing the other day, and boy, those lawyers and that judge were working super hard, having to think really hard, pay attention for hours at a time with no break. It was really something to observe. So in response for, that really high level of skill and that level of dedication, right, society has kind of rewarded them by saying, we will treat you with respect and in general pay you well also. So that's the social contract. You'll hear a little bit more about that in some of the readings for this unit. So when we talk about healthcare professionals specifically, I want to point out that it gets a little muddy when we're talking about the difference between public health professionals and clinical healthcare professionals. So clinical care refers to direct one-on-one providing patient care. So in there, examining patients, prescribing medications, doing an EKG, whatever it might be, actually providing care directly to a patient. Public health, that's not what's happening, right? So you're collecting data, you're analyzing it, you're developing recommendations, you're instituting programs and interventions. You're not doing a lot of the one-on-one work. One of the reasons why there's a lot of overlap is because, of course, a lot of the preventative work that can be done to help prevent disease and illness, which is the major goal of public health, happens during clinical care. So hopefully you remember as a child when you went for your well child checks to your pediatrician or family doctor, they would probably talk to your parents about making sure that you were eating healthy foods and that you had a car seat and you were wearing a seat belt and you used a bike helmet, and making sure you were up to date on your immunizations and vaccinations, and giving you fluoride supplements if you didn't have town water, right? If you had well water that was low in fluoride. So those are all preventative health things that happen in clinical care, which is kind of a public health thing, but so there's that overlap in the actual practice between the two things. There's also a lot of overlap in terms of the professionals themselves. So historically, the people who were public health workers were doctors and physicians. They are doctors and nurses, excuse me. Doctors, physicians are the same thing. And so they just kind of moved into doing public health work. And usually they were also still seeing individual patients and doing clinical care, but not always. Over time, as public health as its own field has evolved, we now have training programs and graduate programs specifically for public health. So we now have a large workforce of public health professionals that are not clinical care healthcare workers, right? They do not learn how to diagnose and treat ear infections because that's not going to be part of the skill set we need them to have. So lots of overlap in terms of the job and historically, right? So most of the public health workers used to also be clinicians or clinical care health professionals. Nowadays, some of them still are. You will see a lot of physicians and nurses and other clinical healthcare professionals that work in public health, but many of them have specific health care. Many other workers are just specifically public health workers or professionals. Okay. So what types of professions do we see in the clinical realm? So providing direct patient care, direct health care. The ones that we tend to see the most, and so the ones I'm just going to talk about briefly here, are kind of nurses and doctors and what are often called mid-levels. So If you're going to become a nurse, so if you're going to become an RN, a licensed nurse, then you're going to get a bachelor's degree in nursing. So you're going to go to college for 4 years. It's going to be a college program that's specifically for nursing. You will have a lot of, lectures and typical classes all about anatomy and physiology and all those types of things, but you will also have some clinical training as part of your 4 years of college. So you will get hands-on training in how to take care of patients during those 4 years. There are some other pathways to becoming an RN, and we don't have time for those. They're really interesting. There's lots of other ways you can do it, but this is kind of the most common historically way that you get into that profession. If you're going to become a nurse practitioner, you do the same thing, but then you go on for additional training. So you go on and get a master's degree, where then you take those clinical skills further. So there would be additional classroom instruction in how to diagnose and treat common conditions, as well as clinical work doing hands-on patient care. So most people who are nurse practitioners have a master's degree. So they've got a bachelor's degree first, usually in nursing, worked as a nurse for a while often, and then got a master's degree. There is now a doctor of nursing practice degree, just to make things confusing, that is out there. You do not need that to become a nurse practitioner, but if you want to spend some more time in school and become more expert, that is an option. Physician assistants are in many ways similar to nurse practitioners in terms of their scope of practice, but their training is kind of similar, except they do it not through nursing schools, they do it through other programs. So they too need a bachelor's degree. Then they need a lot of healthcare experience, oftentimes working as a certified nurse assistant, or working as an EMT, or doing something else where they're doing direct patient care for a period of time so that they have a lot of clinical experience. And then they go and get a master's degree in PA studies, which is usually about 2.5 years, and then after that they are a physician assistant. There are some optional residencies that they can choose to do to kind of further enhance their skill set again, but it is not required. Physicians have the lengthiest training program of the clinical healthcare professionals. So they are going to get a bachelor's degree, just like everybody else, so 4 years of college. Then they're going to go to medical school, which is the doctoral degree, which is 4 years. Master's degrees are generally 2.5 years. They're going to go for 4 years of medical school. And then after their doctoral degree, they then are required to do a residency. And the residency is where physicians then specialize in whatever field of medicine they're going to practice. So for the most part, everyone does the same 4 years of medical school, but then it's what you do after that that determines whether you become a pediatrician or a family doctor or an OBGYN or an internal medicine doctor or a surgeon, for example. So your residency is what determines what field of medicine you go into. Now, if you want to become a specialist, so if you want to become a cardiologist, for example, you would then, and I ran out of room on this slide, you would then do what's called a fellowship, which is usually 1 to 2 or sometimes 3 years. For neurosurgery, I think it's even longer. So you do additional specialized training after your residency, right? Okay. So that's kind of what the training looks like. Along the way, there are certification exams and licensing exams for all of these professions that you need to pass. This slide is just another way of kind of looking at the same information, but kind of talks about it in a little bit more detail. So if you're interested to know just what the differences are, this can be a nice thing to reference. It also includes medical assistants, and you'll see that for prerequisite education, there's none. That's not entirely true. You usually have to have a high school diploma, and then you can do a program where you have some hours in the classroom, about a month, and then about a month of clinical training, and then you can become certified as a medical assistant. As you can see, that is a less rigorous program, and so the base salary is going to be a lot lower than what we see for the others that are listed here. People are often really curious about the difference between nurse practitioners and physician assistants. They're often, as a group, referred to as mid-levels historically because they're kind of in that in-between space between nurses and physicians in terms of the amount of training that they have had. Individuals within those professions felt like mid-levels was a derogatory term, so now you'll often hear advanced practice provider used instead, or just the generic term clinician. The generic term clinician can be used to refer to nurse practitioners, physician assistants, or physicians. So it gets really confusing, right? So both of these mid-levels or advanced practice providers can do a lot of the same things that a physician can. Physician assistants in all states currently need to work in an office where they are supervised by a physician in some way. Usually this does not mean that the physician is looking over each patient that they see. Usually it just means that they are on site or available by phone in case the PA has any questions or wants to run something by them. In terms of nurse practitioners, in some states they can practice independently. They do not need a supervising physician, and in other states they do. It's about half and half, so it varies from place to place. The only other big difference is that nurse practitioners usually have a particular specialty, so they will specialize in family medicine or geriatrics or pediatrics or women's health, whereas physician assistants don't. They have a more generalized education, and so they are often more likely to end up working in specialty offices. They have a lot more freedom in terms of like, oh, I think I'm going to go work in an orthopedics office, or oh, I think I'm going to go work in an ear, nose, and throat doctor's office and assist them. And they're able to do that because they have that supervising physician relationship, which is kind of fun and exciting for those folks. There are also a whole host of what are referred to as allied health professions. Some of the ones that are in this cartoon I would not characterize as allied health because they're actually physicians like osteopaths and podiatrists. But anyway, there's this whole range of healthcare providers, right? All kinds of professionals. So physical therapists, respiratory therapists, cardiac device technologists, operating room technicians, first surgical assistants, ultrasound technicians, laboratory technologists, histotechnicians, speech language pathologists. Those people usually get a doctorate degree. Genetic counselors, they usually have a master's degree, and there are so many more. So there are a gazillion different professions in healthcare. So if you're interested and you want to learn more, just let me know. I'm happy to point you in the right direction. So what about public health professions? So how does someone train to become a public health professional? So you can work in public health as a nurse. And in fact, there are a lot of public health nurses, and they do all kinds of interesting things. Everything from contact tracing, which has been a lot of what they've been doing lately, to going into schools to do educational programs on nutrition or hygiene or other things, going out into the community and doing home visits for people who are parents of very young children that are perhaps at high risk for one reason or another, doing developmental assessments, checking in, making sure the family has the resources they need to adequately care for those children, doing lead investigations. If a child is found to have an elevated blood lead level, they might get involved with the family in figuring out what's going on and helping the family to remediate the situation. So nurses actually are very active. They're a very big part of our public health system. And they, get their RN and then they just decide to go work in public health, which is great. There are also folks that get a bachelor's degree in any of a variety of subjects. So some institutions, some colleges do have bachelor's degree in public health. Also, sometimes it might be in biology or health, wellness, and fitness or applied science or something else. And then you get a job at a public health agency. So they will hire lots of people who have bachelor's degrees. If you want a bit more training in public health specifically, however, to become a public health professional, maybe you want to become the director of a local public health department or part of a disease outbreak team or any of a variety of things, then you would go on and get your master's degree, which is the master's in public health. And there are lots of these programs all over the country. Of course, there's one in Madison. Of course, there's one in the Twin Cities. And sometimes people will get a general master's in public health so they can kind of do lots of different things in public health. Sometimes they will get kind of a concentration in epidemiology or biostatistics or maternal child health or other areas that are of particular interest to them. Another common professional we find in public health is the epidemiologist. So this is that disease detective that's going to look at distribution of disease. They're going to look at who, when, and where, and try to look for group associations and determine the cause of an outbreak and recommend interventions. So those folks may get a master's in public health with a concentration in epidemiology. They may get a master's degree in just epidemiology, or they can go on and get a PhD, which is a doctoral degree, the academic doctoral degree in epidemiology. So epidemiologist is one example of kind of someone with advanced academic credentials who works in public health. Biostatisticians often are as well, and some other folks, but this is just an example. So lots of cool people working together to try to make our world a healthier place. It's like so awesome. Okay, so we're just going to come back to clinical care now, so actually direct taking care of patients instead of public health, and talk about that a little bit more. So there's a couple of different ways we talk about clinical care, and the vocabulary can be a little bit confusing if it's new to you, so I'm just going to go through that. So primary care, secondary care, and tertiary care. So primary care, it's called that because it's kind of your first stop, right? If something is wrong, who are you going to call, right? So who's the first person that you generally call if you need something regarding your health? So this is usually your family doctor, your pediatrician, your internal medicine doctor, or sometimes your OBGYN. So this is the person that you see for most things most of the time. And they have a broad training in the things that commonly occur in their populations. And so they can generally take care of most of the stuff that you would come in for. I would often say, common things are common, and 90% of what's going to walk into a primary care office is going to be one of about 200 things. When you've had that many years of training, it's not hard to be good at about 200 things. But sometimes you have something that's a little bit trickier or a little bit more involved, and they want to refer you to someone who has more expertise in that particular area. So that would be secondary or specialist care. So referring you to somebody who has a higher level of expertise. So perhaps you had COVID and you come to see me because now you just doesn't seem like you can exercise as vigorously as you used to. You get short of breath. And then I'm thinking, well, gosh, could this be some lung damage from the COVID? Could this be that you had myocarditis or some heart damage from the COVID? So I might do an EKG, and I can interpret an EKG as a primary care provider. And then if it looks a little odd or a little funny, then I'm going to send you to a specialist. I'm going to send you to a cardiologist, to someone who has a greater level of expertise. So we need to do that probably, depending on the population, 5 to 10% of the time. In general primary care, we need to refer somebody on to a specialist. Third is tertiary or subspecialist care, so really highly specialized people and or folks that work at like super specialty hospitals and clinics. So I had a thyroid tumor one time, and so I first started my primary care doctor, and then we thought, well, gosh, it's kind of a weird thing. We got an ultrasound, we got some blood tests, we didn't really know what was going on. I was like, well, they could refer me to an endocrinologist, who's a doctor who takes care of things that have to do with hormonal systems like the thyroid here in the region. Or, since the worry was that it was cancer, they could send me to Mayo Rochester, which would be a tertiary care center, and I chose that route, right? And it ended up being fine. Obviously, I'm still here, right? So it's all good. But so that's tertiary care. So those are kind of the uber specialist centers. The other thing we talk about often in healthcare is outpatient and inpatient. And so outpatient just means they're not in the hospital. So this is in the office or the clinic. The patient comes in. You may even do a surgery in an office, but then you send them home. They don't spend the night. Inpatient, you are in the hospital, you are there overnight, they are monitoring you, they are not letting you go. So that's the difference between outpatient and inpatient. All right, so our last section is the healthcare workforce. And so this is something that all of us need to take an interest in because these are people upon whom, of course, our health and well-being depends. So we need to make sure we have enough people in the workforce. And this is tricky because of how many years it takes to train a healthcare professional and because the amount of diligence, intelligence, motivation, and skill that it requires to actually successfully complete that training. So you can't just make anybody into a nurse or a nurse practitioner or a physician. So you kind of have this subset of the population that are people who would probably be successful in that, and they have to want to do it. And then we have to make sure we have enough training programs and enough students entering it so that we are meeting the demand for how many healthcare workers we need. So what has been really interesting is that if you look at employment sectors, which is what this graph is right here, you will see, so in blue, this is manufacturing. And as you may be well aware, we have had a significant decline in the manufacturing sector in our country, which is very unfortunate because those are often good, stable jobs with good benefits, and we are generating value by creating objects. So there's a lot of ramifications to the fact that we have less manufacturing jobs here in this country. Then you can see in green is retail, right? We are shopping a lot, right? And then finally, but then look at this is healthcare, right? Huge growth in, sorry, there's all those highlights, huge growth in the healthcare workforce. And this graph just shows from, 1990 until about 2000, almost to 2020 in this one, right? So, we went from about 6,000 to 16,000, right? So it's more than doubled during this period of time. So really huge growth in that sector. And in fact, the demand is increasing even greater than the supply. And the reason for that is largely and almost entirely due to the fact that our population has been growing and our population has been aging and staying alive longer when they're older, during which time they have more healthcare needs, right? So many of you as young people don't have a lot of healthcare needs. Maybe you need some birth control, maybe you need some STI screening, maybe you get strep throat. Obviously, everybody's getting a lot of COVID tests or whatever right now, but maybe you sprain your wrist or break a leg, maybe you need some stitches here and there. But in general, you don't have heart disease, diabetes, high blood pressure, lung problems. You're not usually on 10 medications all of the time that need monitoring and follow-up, right? So young people tend to not need a lot of healthcare services in general. There are, of course, exceptions. So when we look at this population pyramid here that kind of looks like a butt plug, but anyway, if we look at this population period from 1960 and how many millions of people there were in the different age groups, right? So we can see that, 70 plus was a really, really tiny fraction of the overall population. If we look, this is from 2018, it was the most similar kind of way of grouping those that I could find. And you see, not only are there more people overall, right? So our population has grown, but look at how big, oops, sorry, I didn't mean to animate that one next. Don't pay no attention to that one, right? So look at the 60 to 69-year-olds there with the arrow, right? So we used to have fewer than 5 million men and fewer than 5 million women. Now we have like almost 9 million, right, of both men and women who are of that age group. And then look, for 80 to 84, hardly anyone lived into their 80s in the 1960s, but now we have 3 million people, 3 million men and almost about 4 million women who are living in their 80s. So as we have this aging population, so it's not only a growing population, but an aging population that then has more healthcare needs, we need more and more healthcare workers in order to appropriately provide care for them. So what we're seeing in that graph that I asked you to ignore over on the right-hand side is in purple are job openings in healthcare, and in green are the actual hires, right? So the workforce has not increased in step at all with the demand, right? So as a physician myself, when we were looking to move to Wisconsin, I literally called up Mayo and I said, I'm a family doctor. We're thinking about moving. Do you think you might have a job for me? Nothing was posted. They were like, oh, yes, absolutely. I chose not to work for them because I wanted to teach you guys. But, right, so it is very easy to find a job as a healthcare worker in almost every part of the country. There are certain places where demand and supplies is more evenly matched, like large urban areas, for example, and it's not well matched at all in the most rural areas. We have real shortages. It is harder to get people with a high level of education, often who have lived in cities when they went to graduate school, to choose to live in a small town. So we have a real problem staffing a lot of our rural healthcare centers. So we have a shortage. We've been in a shortage for a really long time, actually. And the pandemic has made it worse. So what we're looking at here is obviously kind of all jobs in orange and then the healthcare jobs, particularly in purple. And I want to point out a couple of things. One is that in general, during a time of a recession, which are the things shown here in gray, usually during the time of recession, you have a little decrease. Oops. Oh, I didn't mean for that to happen. You have a little decrease in jobs, right? Right. Healthcare is usually immune to that, right? So it doesn't matter if the economy is good or not, people are still getting sick. So healthcare is usually immune to that. So the drop that we're seeing in the number of healthcare workers right now is really unprecedented. And so what you see over on the right-hand side is a survey from last spring, actually, so after the first year of the pandemic, where 1 in 4 healthcare workers have considered leaving their job, right? Some of them, yes, to do another job in healthcare, perhaps one that's not quite the same as what they were doing. And then, about 15% were like, I'm just leaving healthcare altogether. And if you think about it, it's understandable. Of course, this picture just gave it away, right? So what we have asked our healthcare workforce to do over the past 2 years has been exceptional. So you don't see it unless you work in a hospital because it's behind closed doors. You drive by the hospital here in town, like, looks fine. You don't see lines outside the door or anything like that. But what's happening inside, especially at these hospitals that have ICUs or that have COVID-19 units, is really devastating. So our healthcare workers have been working double shifts. They've been working 6 and 7 days a week. They've been not taking any vacation for over a year because there just aren't enough people to do the work to meet the demand of all the patients that there are. Not only that, but the work they've had to do has been heartbreaking. The mortality rate that they have seen from COVID-19, the degree of severe illness that they have seen from COVID-19 far outpaces the severity of anything else. Many nurses say, I have never, ever put so many people in body bags. And that takes a huge emotional toll, right? It's devastating. You want your patients to do well, and to have so many people dying has been really difficult. Additionally, it's been really difficult now because a lot of people have had fostered in them a huge mistrust of the medical system through largely disinformation and misinformation campaigns. So now sometimes the people who are coming to the hospital really sick with COVID-19 are then yelling at the doctors and nurses who say, well, you have COVID and we're going to need to do this, and demanding that they give them unproven treatments and denying the treatments that the staff wants to give them, yelling at them. I can't tell you now how many hospitals have had to institute training for their nurses and doctors of what to do if you're being assaulted by a patient. They're being spit on, they're being punched. I mean, it's gotten really bad, right? So the work was really devastating to begin with. Now they're being treated very poorly by a lot of their patients, and a lot of those patients are, of course, people who are unvaccinated and have not been doing what the physicians and nurses have been asking them to do all this time to try to protect themselves. It's been a really devastating time to be a hospital worker, actually. It's really, really emotionally difficult work, even when patients are cooperating with you and grateful, and yet to have it be otherwise is really incredibly difficult. So we're in a bad situation in terms of our healthcare workforce. This is on top of what was already a projected healthcare worker shortage, which is not just in the United States, but nationally. This problem of aging populations is not unique to the United States. And so we are one of many countries in whom there's anticipated to be a significant shortage of workers just in the next 10 years due to physicians retiring and just, the generations. And so this is something that public health also needs to take a look at, and that also policymakers need to take a look at. How can we fix this, right? How can we make sure that we have access to the care we need? I just want to point out that it's not just the professionals. So the number of home health aides, certified nursing assistants, all of those other folks, we are also looking for a shortage, anticipating shortages there as well. These jobs are often underpaid. They're often very difficult. And these people, it's been hard to get people to choose those careers. And now, given the current job market, it's going to be even more difficult. So when we think about the challenges facing us in terms of making sure we have an adequate healthcare workforce, the three things we need to think about are recruitment, making sure people want to pursue all these years of training and hard work to become licensed to become these providers. And so we also need to make sure that the careers look attractive to them. So recruitment is a big part. Interesting for nursing, there's been a lot of outreach to try to get more men interested in nursing because it actually is a great career in lots of ways. So how do we recruit people and get people interested in going into these careers? But a big bottleneck for both physicians and especially for nurses has been a shortage of training programs. So it's pretty difficult actually to find faculty to train future healthcare providers because you're pulling from a pool of people who are healthcare providers, and that's what they trained to be and that's what they wanted to be. And usually, for example, you can make a lot more working as a nurse than you can working as a nursing professor. And a lot of times people who went to nursing school, they wanted to be a nurse. They didn't necessarily want to be a teacher or a professor. And they may not actually have a good skill set for teaching. They might be a fabulous nurse, but not a very good teacher, right? So training programs, finding enough faculty, having enough schools, and having enough clinical training programs to train all of these nurses and physicians and physician assistants and nurse practitioners is a perpetual challenge. There are strides being made, but it's still really difficult. And then once we get people trained, we need to make sure we retain them, right? We need to make sure that they don't quit or retire early, which is a problem right now. So as of the most recent analysis this past fall, almost 1 in 5 healthcare workers have quit. So they've either completely resigned and gone into something else, or they have retired early. So I know a lot of people who are in their late 50s, early 60s who had been planning to keep working for 10 years or more, who after COVID, they hung in there as long as they could, but then they just retired early because it was too much. So we need to make sure that the jobs we are asking people to do are not quite so grueling and demoralizing if we want them to stay in them. So retention is going to be a big challenge, especially once we lose 1 in 5, then the remaining crew have to work harder, right? You know, it's tough. It's tough everywhere right now. Okay, so this was our lecture on healthcare professionals. What does it mean to be a professional? What is that social contract? What are those expectations and obligations? Then we talked about that overlap between clinical and public health and how it can get confusing, both in terms of the roles and in terms of the types of professionals who do those jobs. We talked about some different clinical training pathways, how you become a nurse or an NP, a PA, or a physician, and then some of the public health training pathways that exist as well. We talked about primary versus secondary and tertiary care and inpatient versus outpatient care. And then finally, we talked about the importance of ensuring that we have a sufficiently sized healthcare workforce, and that is going to be a big challenge for us moving into the future. Thank you.